Hello, everyone, and thank you for tuning into my presentation. My name is Jeff Rogers, and I'm a postbac research fellow in the Clinical Pharmacology and Therapeutics Research Branch at the National Institute on Drug Abuse. And today I'll be presenting a secondary data analysis project on how illicit substance use history predicts allostatic load in a clinical population. To establish some background real quick about the concept of allostatic load, drug use activates mechanisms that provide adaptations in response to environmental stressors. These are referred to as allostasis systems. They are a diverse group of mechanisms that involve many neurological structures, most notably the hippocampus and hypothalamus pituitary axis. When these mechanisms are chronically activated, they may begin to pathologically respond, such that an extreme response is provided for future stress challenges. Researchers of this phenomenon have developed the term allostatic load to describe the stress-induced damage to allostasis systems. Because acute substance use constitutes a stress challenge to allostasis systems, chronic substance use may damage these systems, thereby placing the individual at risk for increased chronic disease and complications related to morbidity. One relevant question that arises here is, how do we measure this acquired risk and observe its existence beyond anecdotal observation? There are several current options being employed to measure allostatic load in people with substance use disorders. One being the measurement of telomere length and/or brain structure volumes as outcomes. And these have turned up observable effects. The other being a biomarker panel method by which a set of biomarkers is collected and transformed into a single allostatic load score. Currently, there have been no significant associations between illicit substance use measures and the biomarker panel method of allostatic load. And for the present study design, we collected data from 751 people enrolled in one of two studies. One being a treatment study enrolling people who use opioids, and the other being a natural history study enrolling any adult who consented to participate regardless of drug use status. This collection design generated a more heterogeneous sample than if we collected a biomarker panel from just the treatment cohort alone. We collected blood, urine, and anthropomorphic measures from participants following an overnight fast, a panel of 12 biomarkers representing the metabolic, cardiovascular, neuroendocrine, and immune systems were derived from those samples. Canonical correlation analysis between a group of sample parameter variables and the allostatic load biomarkers was used to generate variable importance weights for each biomarker, and those weights then applied to the biomarker scores prior to summation. This method makes the continuous allostatic load score less generalizable, as it's weighted to sample-specific parameters, but ensures that most relevant biomarkers are represented in the continuous score. For some sample characteristics briefly, here are the means and standard deviations for all continuous measures implemented in the analysis. I know this table is a lot to take in right now, so I provided it under the pretense that you'd be able to pause the recording and come back to it later if you needed to. Also, I'd like to point out that the allostatic load biomarker panel is noted in the bottom section with the red annotation. Some more sample characteristics. For all those curious about what reported use looked like in the sample here, here's a table of sample proportions that fall into each drug use category. About half of the sample reported lifetime drug use, and the proportion of the sample with drug use histories longer than 20 years are fairly small. For the statistical method, the main question driving this secondary analysis was, does illicit substance use increase allostatic load? We tested this question by implementing two multiple regression models. First, we fit a model for the prediction of allostatic load that considers drug use as drug years, as reported on the Addiction Severity Index. This model covariates for demographic factors, perceived stress, traumatic life events, and sleep quality. There have been pretty well documented associations between demographic, psychological, and sleep data and allostatic load, so we really wanted to make sure and covary for those potential confounds where we could. The second model we fit considers drug use as a proportion of life spent using drugs. This was calculated by dividing the ASI drug years by participant age, and the covariates in this model are unchanged from the first, save for the fact that age wasn't included in the model as an independent covariate. Last but not least, we wanted to test if increased allostatic load increased the odds of belonging to a used illicit drugs for greater than 1 year group. So we employed a logistic model with allostatic load and the same covariates as predictors of this dichotomy. Now onto the results. Here we see the years of drug use model. The years model was significant overall with a good R-squared fit of 0.37, Looking at the small table of standardized beta coefficients in the top right corner, we see that opioid and cocaine years were both significant predictors of allostatic load, along with age, African American race, and perceived stress. These factors are considered to predict increased allostatic load beyond what would be acquired with the natural aging process alone. Next, we have the proportion model, where we observe nearly identical effects as the years model, with the exception that alcohol and cannabis also emerge as significant predictors. The standardized coefficients appear much stronger in this model as they are no longer competing with age as an individual covariate, but we see also that increasing alcohol proportions predict increasing allostatic load in this model, whereas greater cannabis use proportions predict lower allostatic load scores. And now, for the sake of making comparisons between these two models, we have a top-down of the model's coefficients. Readily, we see that expected mere exposure effect of age being the strongest predictor of allostatic load. Both models, though, tell more or less the same story about opioid and cocaine use. The more of each tends to correspond to higher allostatic load. And lastly, we have the logistic prediction model that was overall significant with a McFadden pseudo R-squared of 0.28. Overall, we see that the complete model was a good predictor of membership to the have-use group, but was only slightly better than chance for the have-not group. We can consider this model to be sensitive, that is, good at predicting true positives, but not very specific, in that it struggles to distinguish between false positives and true negatives. Moving on to look at the odds ratio plot. This plot shows that allostatic load, perceived stress, sleep quality scores, and traumatic life events were all significant predictors of group membership. Visually, allostatic load looks like the weakest predictor, having an odds ratio of 1.05, but also has a score range that is greater than the other variables, making them all very similar in magnitude when you consider the range of scores for each. Recapping the results, the years model was significant overall and found that increasing opioid and cocaine years predicted increased allostatic load, though age was far and away the strongest predictor in this allostatic load model. The proportion model was also significant, though with a poorer fit comparatively, and provided supporting evidence that lengthier opioid and cocaine use histories may increase allostatic load. Because this model factored age into the drug use measure, alcohol and cannabis use also emerged as significant predictors in this model. In a logistic model, allostatic load was a significant predictor of membership to a greater than 1 year of drug use dichotomy, such that a 10% increase in allostatic load corresponded to a 30% increased likelihood of belonging to the greater than 1 year of drug use dichotomy. Now, some conclusions that we can draw from this study. There is evidence for a relationship between ASI-reported drug years and allostatic load, such that cocaine and heroin and alcohol use may increase allostatic load over a lifetime beyond what is acquired from aging, perceived psychological stress, and poor sleep quality. It's important to note that epidemiologic studies have found no effects between drug use report measures and biomarker allostatic load. Clinical populations may be necessary for this observation, as epidemiologic studies may not accurately capture the marginalized experiences of people with SUD and really stigmatized groups in general. This study was not without its limitations. Because these findings are novel, they need to be replicated elsewhere, prior to drawing strong inferences about the conclusions. We used a very coarse quantification of drug use in that we relied on drug years from the ASI, and it doesn't tell us anything about the amount of drug that was used in the space of that year, just the length of time for which someone was using the drug. And in addition, the cross-sectional methodology does not allow us to confirm that drug use years were causal to increased allostatic load. Again, replication would be great because due to the sample characteristics and its skewedness, we can't readily generalize to the larger population. Here are the references cited earlier in the PowerPoint, and I have some acknowledgments real quick. This project was made possible through the support and guidance of my wonderful mentors at NIDA IRP, Doctors David Epstein, Lee Penlilio, Karen Phillips, and Kinsey Preston. I also want to express my gratitude to the recently passed Dr. Bruce McEwen for the incredible time and energy he spent developing allostatic load theory. All of the analyses and visualizations in this PowerPoint were created using R and Jamovi, so I really appreciate those open source softwares, and I look forward to any questions that you might have about this presentation. You can correspond with me via email at jeff.rogers@nih.gov or attend my Q&A session at 3:30 p.m. on June the 22nd. Thank you for your time.